Hi, Dr. Chan. It's Lynzi DeLuccia with NBC 10. I am just hoping you could talk to me a little bit about the timeline. We see, obviously, like you said, the first three tiers we are administering the vaccine in. With the Biden administration coming in, we're seeing potential for much more vaccine rollout, releasing all of it. We're also seeing potential for emergency use authorization, and more vaccines potentially being approved. Could all of this change the timeline, push it up a little bit? Because when we had first heard, of course, we were thinking January, February. Now we're seeing phase 2 possibly being pushed to end of March, beginning of April.
Yeah, thank you for that question. I will answer the first part, and then maybe Tricia can talk a little bit about some of the timing. But there's been some recent news talking about perhaps opening up additional vaccine supplies, which is very exciting. I think the other thing, too, to keep in mind is that there's other vaccine candidates on the horizon: AstraZeneca, Johnson & Johnson. So the timeline could be much shorter, potentially, hopefully. So we're going to have to wait and see. We are taking direction, of course, from the federal government, as well as from the CDC and FDA in terms of looking at dosing, the amount of doses, the number of vaccine doses that are given. So we're definitely following, again, the best evidence, the best science. CDC, FDA, comprised of national, international experts on this, and following their lead in terms of the guidance. Tricia, do you want to comment a little bit about the timeline?
Sure. Thank you, Dr. Chan. Good afternoon, everyone. So yes, the short answer is that any additional vaccines that are made available to us will certainly help with the timeline. This is new information today, so we still don't know exactly how much more does that mean each week, but we're hoping that we'll find that out within the next day or so.
Okay, thank you so much. And a follow-up to Dr. Nicole Alexander-Scott, I'm not sure if you could talk to me a little bit about that treatment. What exactly is it? Can you kind of explain to people what it is in more depth?
Yes, thank you. I hope you can hear me okay and see me well. We're excited about informing people about this treatment. It's a monoclonal antibody treatment. That means there's a way to provide actively some of the immune response to COVID-19 directly to individuals. It helps achieve what the vaccine is looking to do over time in a very quick amount of time. We have been moved to the front of the line with the federal government in terms of access to the monoclonal antibody treatment, and want to ensure that everyone is aware of the accessibility and availability of it, particularly in our communities that are hardest hit. This treatment is intended prior to someone being admitted to the hospital. And so our hope is, if someone has risk factors that make it more likely that they may be added or admitted to the hospital, we definitely, as soon as possible, want to make sure that they have access to this treatment. So we've been working directly with skilled nursing facilities, assisted living, other senior housing where seniors are. And we also want to engage directly where there are individuals who are known to have underlying illnesses. We especially want to connect directly with our more densely populated communities, because that's where we're seeing more individuals disproportionately impacted by the consequences of COVID-19. And that's exactly where we want to target to ensure that you have access to this treatment once you are confirmed or tested as being positive, confirmed as being positive via COVID-19 test, and you have symptoms. If you're 65 and older, or you have some underlying illnesses, you can be connected directly to your provider, or a provider can be available to you immediately to get access to it. We want to make sure everyone takes advantage of it. We're making it cost effective, as free as possible for everyone who can, and working closely with you to help ensure that you can access it.
Is that available now, and how does someone take it? Is it a capsule? Is it another vaccine? How is it administered?
It's available right away now for everyone who tests positive and who qualifies. It has to be ordered by a provider. So your provider has the information. We've worked closely with our providers to make sure they know where the resources are, where the infusion sites are, how to get their patient connected. And then we also have the Brown Emergency Medicine telecare option that was described, so that you could call and speak to a provider online. That provider can order it for you and get you connected immediately with an infusion site. And we're working to build out as many different infusion sites as possible, particularly at places where there is a lot of testing already occurring, so that you can just go to the next room if you're at one of our testing sites that's able to accommodate this, and get access to the treatment. We want to get at every element. Thank you to some of our local clinical sites also that are partnering with us to make sure that this treatment can be available in all of the different environments that would work well.
Dr. Alexander Scott, I'm wondering if there's...
Journal. Just had a question about, you mentioned the hardest hit communities, and wondering the second tier, the Pawtucket, Providence, Woonsocket, when do you think that they'll be open to widespread clinics for vaccination?
They are next on the list. We have to balance being able to have the supply of the vaccine, and then also the logistics, which we're learning well from our positive experiences with Central Falls. We've already begun discussions with Pawtucket and Providence leadership, and have learned the lessons to start building on the logistics so that we are ready to go when we get the supply that allows for that to happen. So in the coming weeks, we'll be making some determinations about how to do that rollout.
Would this be before the 75-year-olds?
It is on the list along that realm, but we have all of those 75-year-olds as well as the high density communities within phase 1. So we'll be balancing it, because as we have shown, we're not waiting to complete one particular group before starting with another group. We'll be advancing forward as we have the supply of the vaccine available and the logistics set up to make it happen. I want to give Alicia Mahalikis an opportunity to share as well. Alicia and Trisha have been amazing leaders in our vaccination response.
I think you captured it adequately, Dr. Alexander Scott. I mean, again, we keep calling them, the tails of each of the subgroups. So we, for instance, in hospitals, we allocated a large amount of vaccine up front so that they could get their clinical staff and the highest risk staff done first. And then we will continue to provide them with vaccine as they move through the rest of their staff, but that will take a decent amount of time while we have moved on to other priority groups in 1.2 and 1.3. So it doesn't mean that everybody in 1.1 might be done at the end, when we start 1.5 or when we end 1.5, quite frankly, because there's a lot of movement and a lot of change, and everybody is doing some sub-prioritization of their own. So we just try very hard to ensure that we have, an adequate supply of vaccine to activate each of the phases and each of the groups within the phases, because some of them are very, very large. And we are, again, committed to utilizing every dose of vaccine as rapidly as we can, utilizing the equity lens, both, we've been talking about occupational risk, age, and geography, right, as three of the anchoring tenets of equity, so that we can ensure that we are, again, getting Rhode Islanders protected as quickly as possible and in the most equitable, though, imperfect way we can.
Dr. Alexander Scott, it's been no secret that Lieutenant Governor McKee has been, I don't want to say sidelined, but hasn't been a major part of the public-facing portion of COVID management the last almost year. Can you speak to sort of give Rhode Islanders confidence that the Lieutenant Governor, should he become governor, which does seem likely, would be able to be briefed to your satisfaction in a way that he could take over the administrative reins from day one and be in a position where there is no beat skipped? Can you sort of walk us through that process? How difficult is that going to be? And do you believe that it was appropriate for the Lieutenant Governor to sort of be out of the public facing portion of this operation?
Yeah, I can very certainly respond to that. As I mentioned, I spoke briefly with Lieutenant Governor McKee and thanked him because he has expressed commitment to continuity in the COVID-19 response team. Everyone knows how strong the team has been. We've learned so much, we've grown, we've been extremely effective. Rhode Island is at the front of the response nationally. And he understands that and is committed to continuing that progress. So I told him that I look forward to, the executive team looks forward to working with him. He's ready to be briefed. And that's it. We know we are not going to skip a beat, and we're going to keep going forward together.
So all the detail orientation that's been built up over the last, I don't know, 6, 10 months, whatever it's been, you believe that that can be put into the lieutenant governor's hands so he can make decisions in a leadership capacity that would match the same information that Governor Raimondo has had over the last 6 to 10 months. That can be done in the amount of time you'll have to brief the lieutenant governor?
Yes.
Thank you.
This is
Doctor,
Michael
a
Bello
follow-up
from
on my
Motif.
earlier question. When, in terms of the number of people vaccinated, will we expect to see an effect in our daily and weekly numbers?
So I can take first shot at that, and then Alicia or Tricia, if you have anything to add. So I think folks have to remember that the vaccine is part of our COVID-19 response, an important part, a critical part, but a part nonetheless. So it's going to have to do with continued physical distancing, masking. There's going to be natural declines. As we all know, we're in a terrible second wave here in Rhode Island. That's going to naturally come down over time. Hopefully vaccines will help speed that up. So it's going to be a combination of a lot of things. And hopefully when we're done this second wave here, hopefully that's it, especially as we get more people vaccinated. And we're looking for that herd immunity effect to take place, which will hopefully contribute and start this spring, certainly now as we're vaccinating, into the spring and the summer.
Thank you.
I can take that. So we did receive information from CDC that Rhode Island would receive around $9.6 million. So that's the overall total for Rhode Island. There's still some things that we have to dig into because that was just released yesterday, but that's the overall amount. For the COVID-19 supplemental funding, for COVID-19 vaccine supplemental funding, yes.
This is Michael Bello from MotifRI.com. Two related questions following from the idea of the variant. It's suspected anyway, or reported, that the variant is more transmissible, although I understand that the data is lousy. But the UK government has said that they estimate that the variant has about a 0.4 increase in R0. So first, does that increased transmissibility affect your expectations if that eventually does become prevalent in Rhode Island, as you've said you expect, in terms of what sort of public health measures will be necessary to contain it? In particular, will there be further restrictions, do you think, because of that increased transmissibility on possibly school closures or moving schools to more online or hybrid models, or even things like restaurants, gyms, and something similar to what we saw during the pause? And then secondly, you've been allocating risk groups among the various phases of vaccination based on, as I understand it, a combination of risk of exposure and infection and risk of complication, hospitalization, or death. And so does the increased transmissibility of that variant change how you perform the balancing test in evaluation of risk of certain subpopulations? So certain subpopulations, I don't know, like school children or K through 12 school children would be, at relatively lower risk of complications, but higher risk of exposure.
Two excellent questions. So indeed, the data is pointing towards the fact that the variant is more transmissible. Thankfully, it is not yet showing evidence that it is more severe. So in terms of the transmissibility, we have the critical tools in place that work. To stop spread, we know that masks work, we know that distancing yourself works, and washing your hands. And it's all the more reason why we want to really point to the importance of doing that, particularly during this final phase. There's going to be time before we have enough of the population vaccinated. The risk of transmitting and acquiring COVID-19 is going to continue, if not increase, due to this strain, and the importance of individuals being able to mask when they're with someone that they don't live with, keep their distance, and wash their hands remains all the more paramount. If those measures can continue, we would be able to deal with the more transmissible version of this variant in Rhode Island, which we know it would not surprise us if it were here. So we need to make sure that individuals know the importance of continuing those critical measures. If those continued measures can occur, there would be less of a need to move towards restrictions, but time will tell. How are people able to do in continuing to follow those rules? More transmissibility means more cases and could mean more hospitalizations. To that end, on the vaccine realm, particularly because we have the ability for masking, hand washing, and distancing to control the transmissibility, we want to continue to preserve life and to preserve our healthcare system and the capacity of our healthcare system. And that's really the focus with the vaccine. That being said, we all know how dynamic this response has been, and we are constantly looking at the data, evaluating the science, and we'll make adjustments that we need to keep Rhode Island a step ahead to the extent that we can.
Thank you, Director. Can you talk a bit about the variant being detected? In other words, you said it hasn't been detected yet in Rhode Island, but what exactly is Rhode Island doing to facilitate that detection, because everybody expects it's eventually going to arrive, and how long do you think the time frame would be between its arrival and its detection? In other words, how long does it take before you can genomically sequence the virus out of enough samples that you're going to find this?
So once again, thanks to our state health laboratory with the Rhode Island Department of Health, led by Dr. King, and the amazing team that has brought us through this pandemic since day one, when we first identified. Dr. King and the team at Rideau State Health Lab have been leading the process for doing the sequencing. It's full molecular genomic sequencing that's going to allow us to determine if the variant is present. We start with a screening part to that process, and then have been building our partnerships either with neighboring states or with the federal government to do the more extensive and complicated process. We are developing a systematic approach to assessing assessing the presence of virus in the state, and to do a sequencing process that will allow us to be even a step ahead of a few other states in terms of the number of specimens that we will be systematically evaluating for sequencing. So it's really a matter of time before we actually identify it, but we can be confident that there is a comprehensive approach in place to continue to assess whether or not it's here in the state. In the meanwhile, we want to make clear to individuals that masking, distancing, washing your hands works regardless of if the variant is here or not. We need to make sure that we stay vigilant in doing it because it's likely that the variant could be here. And we're thankful that the vaccine is at this time also effective against this variant too.
Mary MacDonald, did you have a question?
I did. I was just going to shout out. Dr. Scott, I had a question about how you're prioritizing people who have comorbidities that have been sort of, I guess, shown to have more severe COVID. Thinking of people who might have cancer, who've recovered from cancer, weakened immune systems, or people who have diabetes, whatever. Are they only being prioritized for vaccines based on their age? I just don't see them listed in your graphics. Where do they fit in? And is that being reevaluated?
So that group is also a priority group as well as age, and along the lines as what Dr. Chan has explained, as we go forward with phase 2 and providing more details, you'll be hearing more about how they are prioritized.
Sorry to interrupt, they are phase 2, they're not in phase 1.
There's a combination. There are different components of where we're going to see it in phase 1, that people with underlying illnesses are identified. And then as we get into phase 2, we'll be providing more detail. Is there anything else you want to add, Dr. Chan or Alicia and Tricia?
I'll say that's absolutely correct. I will say for some of the settings that we have been vaccinating at, for example, the ACI, certain places within Central Falls, we're definitely focusing on older adults in general and those with other significant medical conditions. I think for the general public, phase 2 is where for others with significant comorbid underlying conditions like cancer are likely going to fall.
Okay, and just one quick follow-up that's unrelated, really. It's not a follow-up. Is there any talk about having more frequent briefings? When this thing was going in the spring and early summer, the governor was having multiple, days. I think for a while it was 7 days a week. Now it's like every 2 weeks. Is there talk about having more frequent briefings for the public that's asking a lot of questions about vaccine distribution?
Yeah, I'm sure Joseph can add to that as well. We will certainly be continuing the weekly press conferences, but have added additional media availability touch points each week in addition to that. And we'll continue engaging with our providers, engaging with members of the public, and certainly welcome additional ways to strengthen the communication because we know how critical that is to the response.
Okay, thank you.
Hi, doctors. It's Steph Machado. I'm curious about the new texting system to tell people to quarantine. Are you concerned about compliance at all? Because I know it's a lot easier to ignore an automated text message telling you to quarantine for 10 days rather than a person calling you and saying, this is what you have to do. These are the rules. We know you've been exposed. We know you're a close contact. Can you speak to that?
Yeah, this is intended to actually help with compliance because compliance is always a concern. We know it's not easy. I've experienced it as well, but we know that it is a critical tool to stopping the spread, especially as we were having conversations about having a potentially more transmissible virus present. So the texting approach allows us to not only provide that initial reminder, but hopefully to continue to build a way to maintain that communication and to keep those reminders going. It's really adding additional reinforcements. We can always also reach out and call to help if we have any challenges. That's not going to go away as a backup, but we're really using technology to help bolster the support for knowing the importance of quarantining and to remind people. It's something that people are more familiar with, and we want to get at this from every angle possible.
And is this replacing the existing human contact tracers, or are they staying on? Are they going to take up other duties?
No, that's why I mentioned, you know, in situations where it's either more complicated or we weren't able to get through effectively, our contact tracers are absolutely involved in helping to still do the work. This just allows us to really focus in on the ones where we absolutely want to stop transmission, whether there was an outbreak or persons involved that are at higher risk or persons who weren't able to be communicated with. It also allows us to help be more effective. As we are building out our testing sites, we're looking to have more active involvement with reaching people and connecting to them on the front lines while they're there, encouraging additional testing. So it gives us the flexibility to even be even more responsive as a team in meeting people where they are and helping them to do the isolation or quarantine or get the supports that they need, the treatment that they need, and other supports for food or otherwise.
Okay, and you're using the texting system for the K-12 system as well? The K-12 testing system?
It's going to be a mixture. I believe it is available for that as well, but we will also be maintaining some form of you know, firsthand communication as we need to.
Okay, thank you.
Dr. Alexander Scott, and let me preface this by saying that no is a perfectly good answer to this question. But do you have any, you're one of the most visible people in the state's response. Do you have anything you'd like to share about your personal experience with COVID-19 that you think would be of value to the public or to clinicians?
The takeaway that was from my experience is really to use it to encourage Rhode Islanders to think about what they need to do to protect their household. I saw and continue to see getting tested regularly, masking, distancing as the critical tools for ensuring that people in my home stayed safe. And I was grateful to know that with regular testing, I was able to identify whether or not COVID-19 was present and do what I needed to do to protect my young son and baby and to protect those in my household from getting infected, because I could wear a mask inside the house, stay isolated, and do what's needed. So I really want to promote that for Rhode Islanders. We are putting forward the tools to protect you and the people within your household. So getting tested regularly is key, getting access to the treatment that we're talking about, and then being ready for vaccination as that comes available as well.
Dr. Alexander Scott, just to circle back to the surge the state was potentially expecting after the holidays, you said there was an uptick in percent positive, of course, that we saw, but hospitalizations were down. Can you explain that? Why were we seeing more of these cases and hospitalizations still down? Is there a difference in the virus? Are different ages contracting it at this point? Can you kind of explain that?
We are still understanding the outcomes of what happened during the holidays. We know that there is a lag between when cases go up, then when hospitalizations, and unfortunately when deaths occur. So we saw a slight increase in cases. If the hospitalizations go up, there will be a lag to that happening, and it could start to happen in the next couple of weeks. But if people hear this message and double down further, stop some of the transmission of COVID-19 by the masking, by the distancing, washing your hands, get tested regularly, do what's needed that we're saying to protect your household, we could stem off more of that increase in cases and hopefully prevent the ultimate lag that sometimes identifies itself in increase in hospitalizations. Our overall key is preserving our healthcare system capacity. And so we're hopeful that with this messaging, with people understanding how critical it is, that cases have started to increase. But if you make that change now, continue to really be vigilant, protecting your household, we could continue to preserve the hospital capacity the way we need to.
Bill,
Thank
did you
you.
have a question? Bill?
Yes, just quickly, what did we learn from being one of the Pfizer trial states? What have we gained from that here in the vaccination rollout? Has anything come of that in modern times, as in right now, I guess?
Well, I'll let Tricia be able to respond further, but I know that with the strength of the team and the experience, our operational leaders, Courtney Hawkins, the support and public health experience and leadership with Tricia and Alicia, that many neighboring states, other stakeholders have been learning from us as we have learned from them. But you'll be able to say if there's anything further or if it's more so just been Pfizer taking that information and lessons learned and applying it as they've contributed to the rollout nationwide.
Yeah, thank you, Director. It was definitely mutually beneficial for Pfizer and for us as well. We learned this was more about distribution planning, that, you know, rather it wasn't a trial so much, but it was distribution planning and operations. It helped us learn a lot more about what we needed to do and the work that we needed to do with our partners. It helped Pfizer understand kind of what some of the operational logistics might be for individual states. Every state's a little bit different. So I think it helped us get moving a little bit maybe smoother in the beginning. We were able to message with our partners very effectively about what we learned directly working with Pfizer. I'll now defer to Alicia because I'm sure that she'll have additional information to add as well.
You know, I think that's exactly it. It was such a phenomenal opportunity for us to hear firsthand the things that they were not only learning and pushing, but also the things that were still evolving. And we had the opportunity to be at the ground level for some of the new modalities for vaccine management that they wanted to be testing, because this is a unique vaccine that has, you know, very unique attributes, especially in terms of the ultra cold chain. So number one, we had firsthand access whenever we had a question, and they could not have been more responsive. They were truly phenomenal on that front. But also it just gave us that grounding opportunity, as Trish mentioned, for them to say, like, this, we don't do this on the ground every day. So let's hear it from you, like how you're planning to implement this. What does that mean in Rhode Island? Here's what we heard from Texas, which is another one of the states. You know, is this similar or different, right? We don't have counties, we don't have local or county health departments. Things work differently in different states. And they were really receptive to the idea of developing guidance and planning tools that could be more broadly applicable and not trying to create a cookie cutter approach that might not work for everybody. And every time we went to them with a problem, they were willing to consider, you know, different solutions for it, which I thought was, again, a tremendous opportunity for us to voice the things that we found challenging and to work with them jointly to try to find solutions. And it was very nice to be respected in that way.
Mary, did you have a question?
I did, thank you. I just had a quick question about this flyer that came to my house from the Rhode Island Department of Health. It's got Dr. Chan's picture in the inside, and it says COVID-19 vaccines are coming to Rhode Island. This is in English only. It came to my apartment building, and there's, I was just curious, so is this going to go out in multiple languages? Is this going out across the state, or is it just going to Providence? Can somebody describe this a little bit? And is this the beginning of a broader advertising campaign on the vaccine?
Yeah, I could take a stab at that, Mary. So this is one piece of a very broad campaign that we are going to be doing to do some education and promotion about the importance of getting vaccinated. So we are going to be doing a lot of outreach in multiple languages. So that was just the the first push that we're doing, but we are going to be doing it in communities throughout the state. So no, it's not just Providence. So people should expect to see more of that material out in different formats and different settings over the next several weeks and several months.
Okay. All right. And sorry, was this funded with the federal stimulus dollars? Is this part of what this, how is this funded?
Yeah, I will look into the specific details on that mailing, Mary, and get that to you offline. But
thanks.
Sophie, did you have a question?
I did. Sorry to jump on you, Mary.
No worry.
I was wondering about the contact tracing, your new sort of automated contact tracing system. During the fall, I know there was a pretty serious backlog in the contact tracing system where people were not, being contacted in time to really do contact tracing. Do you still have a backlog? What's the status right now?
Yeah, I'm thrilled to say, because of tremendous work across the board from the entire team, we have not had a backlog as significant as that time since that time. We worked really hard to put systems in place, be innovative and creative. We have a diligent team across the board, whole of government, that has really done what's needed to remove the type of backlog that we were having then. And this is one of the various ways of being innovative to help ensure that we don't have that type of backlog. You see the types of, the number of cases that we're having each day. So it's quite the accomplishment to know that we're able to get through those each day, knowing where we started. And it's because of innovative technology updates like what we shared, along with just tremendous work, creativity, and diligence in doing what we needed to have the systems in place to allow us to respond effectively.
So, to clarify, you said we don't have as significant a backlog as we did at that point. Do you still have a backlog that's just smaller?
No, because the backlogs we were talking about then were over a few days. We'll have a large number, but within the 24 hours, the normal time frame to get through those cases, we are getting through them. They are not accumulating the way it had happened over that short time period then.
Okay, thank you.
How are we doing on testing? In other words, what's the volume of testing both in the ordinary system and the K-12 system? How close is that to where you want it to be? Where do you see that going over the next few weeks, increasing, decreasing? What do we need? What do we have? And what's the turnaround time for that? I know you monitor it.
Yep. Although we continue to lead the nation consistently in testing, we have recognized with the 3 major tools that's going to get us through the remainder of this pandemic, that continued targeted, expanded testing is going to be critical, along with the treatment that needs to accompany it so that individuals know they have access to treatment and can get it when they qualify and help to keep them out of the hospitals, and then certainly vaccines. So going forward, we're continually looking for ways to expand access to testing. We know we'll have the capacity, and that's growing as well, but also want to drive the demand and help people know that regular testing once a week, particularly if you're working in certain fields where you're exposed to the public, or you have this as a way to really protect your household, or you know that you may be exposed because you're either older or have some underlying illnesses. Getting tested regularly is that first step. And so at the state level, we want to continue making sure, whether it was the pop-up testing or having it in some of our more densely populated communities, or testing more in schools, we want to continue to make sure that that is available. And with all credit to our laboratories, starting with the state health lab and the private labs throughout the state, our test turnaround time, no matter how much we have continued to expand, has continued to stay strong. 1 day, 2 days, we have maintained that over the last several weeks, if not months, and that will continue. So Rhode Islanders can really be confident. We're leading the nation and looking to go even further in how we're doing with testing, access to treatment, and vaccines as those key tools to being able to protect your household and keep your loved ones safe.
So to be clear, your current recommendation for everybody in the state really is get tested once a week or more often as you need, and you have the capacity to deal with that.
Yes, as many people as who can get tested regularly, particularly those that are at the highest risk. Everyone should get tested, particularly those who I've talked about and given as examples, get tested regularly. Once a week is regularly, it could be every other week, it could be more frequently than that. The more you know, and continue to stay diligent, wearing your masks, keeping your distance, washing your hands. Those are all of the tools that are going to work as we get through the final phases of this.
Do we have a last question? We have time for one more.
Well, I'll take it if no one else is jumping on it. I'm wondering what your plan is to release the updated vaccination plan. The current one published is from October, and also whether you're planning to release more specific regular data on vaccination as Massachusetts and other states are doing.
Yeah, we spent the original time of this vaccination rollout really making sure that we're strong from a logistics standpoint and learning from the lessons that Trish and Alicia shared early on. And now we're going to continue to bolster that with our focus on the communications piece, which is its own entity connected to that. So we want to look at ways to really make data available as we're continuing to get it now that we have the systems working and moving, look at ways to be able to inform people about vaccine availability as we are going to receive more from the feds and be able to distribute more. And we'll welcome input from you on what will work well for continuing to make sure that communication is there. You know, Dr. Chan referenced to our providers earlier. You know, we hear you, we hear everyone, we hear those who are saying that, you know, it's important to get vaccinated. And we want to make sure that our communication is reflecting that, honoring who they are and knowing how important it is, and helping to understand just how dynamic and complex this process is. We can assure you there's no one sitting around just letting vaccine be wasted or in any way. We have a system in place to make sure as we get it, it's getting redistributed and safely getting administered. We have to handle it differently because of COVID. We got to set up schedules and make sure that people are coming in at specific times, but we are focused on getting this done successfully. And so we appreciate everyone partnering with us to make it happen.
Great, everyone. Thank you for being with us today, and we will see you next week. Thank you. Have a good weekend.
Yeah.
Is the state adequately staffed to give them out quickly? Or would that present some challenges, or are you guys working on plans well, if that happens?
Lynzi, I think, you know, we have a lot of different partners who can administer vaccine. We've been working, you know, slowly and methodically to get them through the COVID provider agreement, which is something that the CDC mandates of us if you're going to be administering COVID-19 vaccine. And it's a lot of work, both on their part and our part. So again, we've been trying to do it in a methodical rollout so that we can get as many providers in and get them ready to vaccinate when vaccine becomes available. There will be some challenges in redistribution just because the minimum dose requirements for ordering are high. So for Pfizer vaccine, the minimum dose order is 975, and you can only order in aliquots of 975 doses, right? You can't order directly from from Pfizer in anything smaller than that or anything different than 975. So we've all learned how many 975 0.75 times 2 times 3 times 4 is. So the Moderna is a little bit easier to manage because it comes in 100 dose increments. But still, there are some places where we want to do vaccination where 100 is still too many. So for instance, for outpatient providers, our urgent care centers, our respiratory clinics, those urgent cares and respiratory clinics started this week, or last week, but many of them wanted to do the vaccination. They're very eager to be part of the process. So we're walking them through the paperwork, but it would still be very difficult to allocate to them when they're only vaccinating their staff. So again, we're really trying to be cognizant of what the stress is on the healthcare system and where capacity does and does not exist, so that we're ready to utilize our regular partners, because that's what makes our immunization program so tremendously successful. And I'm sad that Trish dropped off, but she has been a tremendous leader on that front to really helping us move toward and stay at the edge, at the cutting edge of vaccination for the state. And the partners in this state, including, our insurance partners, are truly phenomenal. So we want to utilize the capacity. We want to use, where we have proof of concept. And then we've been working with our mass vaccinator partners and others to build additional capacity. So we continue to explore ways that we can maximize that capacity, again, based on different scenarios that we've run in terms of how much vaccine could potentially become available, either because of what the Biden administration is proposing, or when AstraZeneca and Johnson & Johnson or others come online. So we're really hopeful that but by doing early groundwork, we will have prepared ourselves well to be able to take on that capacity.
Great.
So I really appreciate that.
Yeah. Thank you very much. Okay, everyone. Thanks so much. We'll see you next week.